Welcome, everyone. My name is Bryce Peterson. I am the Marketing Communications Manager here at Ecovia. This webinar is part of a larger series of webinars that we are presenting over the next month or two, surrounding coordinated assessment and coordinated entry, both somewhat interchangeable terms in the HMIS and COC world. What we are seeing as a company is that many smaller communities specifically have tended to struggle with coordinated assessment or coordinated entry. And what we are doing with this webinar series between leading COC agencies from Houston, Atlanta, Georgia, and Dallas is to show you folks how data sharing can lead to better client outcomes. Now, the reason this is such a big topic right now, obviously we had the recent SCOTUS decision on Grants Pass v. Johnson, which promises to be a potentially groundbreaking case that could have downstream consequences for homeless populations. So, what we aim to do is to show you how coordinated assessment can lead to better client outcomes and how we can mitigate homelessness and achieve potentially functional zero. So today we are joined by the Coalition for the Homeless of Houston, Harris County from Houston, Texas. And I will go ahead and introduce our presenters. First up, we have Anna Rausch, the recent VP of Program Operations. Anna Rausch is a results-driven executive with more than 23 years of experience leading supportive housing organizations. She focuses on project management and system change implementation, and recently served as the Vice President of Program Operations for the Coalition for the Homeless of Houston/Harris County, the lead agency for the Texas-700 continuum of care called The Way Home. In this role, she recently led the agency's HMIS and program operations teams and has led in the development and implementation of nationally recognized programs and strategies that led to a 62% reduction in homelessness in a 10-year period. In addition, she implemented The Way Home's coordinated access system and spearheaded the revised and improved methodology used during the COC's homeless count, I believe the PIT, correct? And helped develop the COC's encampment response strategy. Originally from Brazil, Anna lives in the Northwest Houston area. She has been featured in numerous media articles and holds both a bachelor's and master's degrees in psychology. Just give us a wave, Anna. I believe you already did, but yeah, thank you. And then after that, we have Errol Fatahajic, Director of Analytics and Evaluation at the Coalition for the Homeless of Houston/Harris County. He has been with the organization since July 2008, and in his role, Errol oversees the Coalition's Homeless Management Information System support and data analytics team. He is passionate about using accurate data to provide real-world solutions without biases. Previously, Errol served as a housing coordinator, technical support specialist, and system administrator. Originally from Sarajevo, Bosnia, Errol studied civil engineering and computer science. Give us a wave, Errol. Thank you. Next up, we have Renee Cavazos. Renee is the VP of the Homeless Response System Planning and Implementation. She has been with the organization since September 2016. And in her role, Renee focuses on ensuring customer service to the Coalition's partners, leading to high levels of performance, both quantitatively and qualitatively. Very important distinction. She is deeply committed to making a positive difference in the lives of individuals throughout the COC region. Previously, Renee served as a client services specialist for the Crisis Center of Comal County. Next up, we have Jordan Jupe, Manager of Coordinated Access and Intake. Jordan has been with the Coalition for about 3 years, over 3 years actually, and is committed to ensuring access and efficiency for individuals experiencing homelessness throughout the region. Previously, Jordan has served the COC by overseeing the Rapid Rehousing Program and as a direct service provider at one of Houston's largest day centers. She is an alumna of the University of Houston's Graduate College of Social Work. So, now for those of you coming in who just barely came in, go ahead and leave a message in the chat where you're from, what organization you're with. We'd love to hear from you. We will have brief Q&A between each presenter for any questions that can be answered quickly. But for more detailed, involved questions, go ahead and put those in the chat, but try to save them toward the end for the Q&A section. We have Melissa Wheeler on the line, who is an HMIS expert who will from Ecovia, who will be able to answer any specific questions about ClientConnect. But this webinar is just as much for people wanting to learn about coordinated assessment in general. So without further ado, Anna, take it away and let me know when you need your next slides.
Alrighty, thank you. Hello, everyone. Thanks for having me today. This is very exciting to talk about our coordinated entry process in Houston. So I can't start a webinar or a presentation without talking about the size of our geographic area. So what you see in front of you is just Harris County. So you can see all of the different cities that fit into Harris County, and then the city limits of Houston, which are the ones in gray. And so Houston, the city of Houston alone is 665 square miles, and this is larger than the cities of Chicago, Dallas, Los Angeles, New York, Phoenix, and San Diego. If Houston were a country, it would rank as the 26th largest in the world. And then Metro Houston has the third largest number of Fortune 1000 companies in the nation and ranks fourth in Fortune 500 companies. And lastly, the Texas Medical Center is the largest medical center in the world. And the medical complex boasts more square footage than downtown Dallas. So we're very proud of our medical center. Next slide, please. This is just a fun slide that I use because I'm a huge Disney fan. And so this was in our Houstonia magazine. So Houston one of these, if you look down at the bottom, one Mickey Mouse is 5 Disney Worlds. So if you've been to Disney World, you know how large it is. So this is how many Disney Worlds can fit into the city of Houston. The number of Grand Canyons, the number of San Francisco bridges. So you can see we have a very, very large area just in the city limits of Houston. Next slide. And so we actually have 3 counties. Harris is where Houston sits, but we have Montgomery County to the north. It's more of a rural area. And then Fort Bend County to the west. It's more affluent. And so overall, this is about 3,700 square miles of area that we have to cover. Next slide. And so the Coalition for the Homeless, we're different than other nonprofits you may be familiar with because we do not provide direct services to people experiencing homelessness. We are an intermediary capacity building organization. So one way to think about it is to think about air travel. The airlines are the ones actually moving passengers from point A to point B, and they rely on the support of the airport and the air traffic control to make sure it is done efficiently and effectively, So when you apply this analogy to homelessness, the coalition is like the airport or like air traffic control, and the individual service providers are like the airlines. Both rely on each other and work hand in hand to get people from homelessness to housing. Next slide. And so the way home is just what we renamed our continuum of care. So TX 700 is the way home. It is more than 100 partners working together from all across the counties, nonprofits, government organizations, philanthropy, faith-based organization. And it is our collaborative model to prevent and end homelessness in Harris, Fort Bend, and Montgomery counties. Next slide. So back in 2011, Houston was not doing very well. We had the 5th largest homeless population in the country. We were spending millions of dollars, but still leaving money on the table. And we all know what happens when we leave money on the table. It gets recaptured and we don't get to reuse it again. Homeless service providers were operating in silos with no collaboration. No one really knew what other organizations were doing. There was a lot of duplication of services. Recidivism was high. We weren't matching people to the right programs. Housing ready philosophy was keeping hard to serve on the streets. We weren't really doing a lot of housing first. We know that homelessness is expensive, and responding to that with emergency services was not effective. And then lastly, we didn't really, none of the partners knew what the collaborative applicant was doing. That was the coalition at the time. We were not the lead agency. And so no one really knew how to get new PSH or rapid rehousing projects, permanent supportive housing or rapid rehousing projects, how to get new funding, because we were operating in these silos. And so we had a shift in 2012. We were identified as a priority community by HUD, not because we were doing well, but because we were doing poorly. And so that gave us some technical assistance that came into town. And we had a community charrette over a 3-day period where we invited all homeless service providers, as well as those that touch the homeless response system, such as the VA, the housing authorities. And we got together and tried to figure out what we were doing wrong, what we were doing right, empowering partners that were doing something effectively to do it better, and those that were not doing something effectively, moving it to others that could do it better. This led to the collaborative model that we have today. And so the coalition became the effective, we had our first 5-year strategic plan, and the coalition was named as the official lead agency to the Way Home continuum of care. Next slide. And so from that 5-year strategic plan, we actually we were supposed to create 2,500 slots of permanent supportive housing. We actually ended up creating almost 3,000 slots. And when I say slot, I mean 3 things: the unit, that's the actual physical unit where the individual is going to reside, the subsidy that's going to pay the rent, and then the supportive services. Because if you don't have all 3 of those, you don't have a housing slot. So we ended up creating almost 3,000 slots of permanent supportive housing. We declared an effective end to veteran homelessness in 2015. And so that means that we reached functional zero. It doesn't mean that we don't have any homeless veterans on the streets. What it means is that if we were to take every single homeless veteran today, we could actually house them within 30 days, which would make that their homelessness rare, brief, and non-recurring. We implemented coordinated entry in 2014. We were actually one of the first cities in the nation to do so. We did it before HUD put out their data standards for coordinated entry. We decreased homelessness by 61%. We housed more than 30,000 individuals from 2011 until today. Next slide. So this is what access to housing looked like before coordinated entry. We're all very familiar with how this works. The lines represent people moving through our system. Not very effective. You're likely to be told that shelters are full. A lot of backdoor, side door conversations are happening. So for example, if I've been in the system a while and I know people that are in housing programs, I can pick up the phone and say, hey, I have a client that I need to get into a housing program. And then my connection would get that client in, rather than people experiencing that are the most vulnerable in our community getting into that housing slot. There was also a lot of duplication of services. So because we were working in silos, individuals were receiving multiple services of the same thing, but no one knew about it because we weren't really communicating. We were putting people in the housing intervention that were incorrect for what they needed. So people that were very vulnerable were getting put into short-term interventions. And so that just led to them becoming homeless again. And then people that really didn't need permanent supportive housing or long-term housing were being put into that intervention. And so that was leaving a lot of very vulnerable people on the streets, dying on the streets. Next slide. And so this is the current access to housing today. So you can see the access points there, the hospital's intake line. This is one of the things that we have to have for coordinated entry. Has to be accessible. And so we have it in multiple areas around our continuum of care. Everything happens within HMIS. The consent happens within HMIS. People can sign on a tablet, using a mouse on a computer, or even on a cell phone. The matching for permanent supportive housing or rapid housing happens in HMIS. Individuals get placed on the wait list, they get referred, and ultimately assigned to a navigator all through HMIS. The questions are very simple. It does not take long, and individuals don't have to repeat their story because everything lives within HMIS. Next slide. And so what you see here is our first coordinated access HMIS workflow. And so one thing I forgot to mention, in Houston, we call coordinated entry coordinated access. Because again, in 2012, when HUD first started talking about coordinated entry, they didn't really have a term for it. They called it centralized access, coordinated entry. There were a lot of different terms used. And so in Houston, we decided on coordinated access because we are so large. It made more sense to make it a coordinated access system. So of course, then several years later, HUD implemented the term coordinated entry, and so we just didn't want to change our term, and we kept the coordinated access. But what you see here is what the workflow looked like in HMIS. There's a workflow that we can add the client or edit the client, and then there's the information on the client's demographics, et cetera. There's the homeless service housing eligibility. So we started coordinated entry with permanent supportive housing. We do not have shelter in our coordinated entry system because we don't have a lot of shelter in Houston. Most of them are privately funded. And so it just made sense because we were trying to end chronic homelessness and we were trying to end veteran homelessness that we wanted to start with permanent supportive housing. The next set of questions involve DV or VA. So if the person is experiencing homelessness as a direct result of or fleeing domestic violence, or if someone is a veteran, then the workflow will stop and it would generate a referral directly to those two systems. From there, it would determine if the individual, based on their homeless history, if they were experiencing chronic homelessness, which would point them towards permanent supportive housing. And then if they were experiencing rapid rehousing, they would go to the rapid rehousing workflow. If they were experiencing chronic homelessness, the VI, the vulnerability index, is what we started with. And then from there, it would generate a vulnerability score. It would match the individual to an actual housing program based on their characteristics. Because back then, we still had some housing programs that were serving a certain population. Once we implemented coordinated entry, we got rid of that. And then from there, everybody got placed on the wait list because we didn't have availability right away. But back then, we did have a lot of PSH slots, so we were able to refer individuals pretty quickly. The referral happens in HMIS. And then the individual project will receive that referral in an email. And then there is a required document list that we had all assessors and navigators complete, which they then uploaded into HMIS. Next slide. And so one of the questions that I used to get a lot of when we were presenting on coordinated entry in the beginning is, how did we support it? So the first thing that we did is we looked at the data. So we looked at where individuals experiencing homelessness were touching the most places. So that ended up being our largest day center, where we learned that the majority of people experiencing homelessness in our community were going to that day center either to take a shower, to get a referral, to get their laundry done, to get a meal. And then we had our largest women and family shelter, which was the second access point. And so we decided that those were going to be our first two assessment hubs. So go to where the people are. And then we had, how are we going to fund assessors and how are we going to fund navigators? So the navigation term is something that we started back then, which was we wanted to have a person who is going to assess the individual. And then we wanted to have a person who is going to literally take the person by the hand and do whatever it takes to get them housed until the day that they move in. It's not about fostering independence. It's all about enabling the person, because the old way of doing things, when we would hand someone a packet and ask them to come back, just wasn't working. And so the term navigator came up. But we didn't have funding for coordinated entry back then. So how could we make this happen? So what we did is we had the two largest day centers had had intake staff paid by ESG that were doing intake for those organizations. And so we went to the funders at the city and the county, and we said, is it okay if these individuals can do intakes for the system instead of just for their organizations? You'll still be able to collect information needed for the ESG requirements, but instead of doing it just for that organization, they're going to be doing it on behalf of the system. And so this was okayed. We went to the two partners, we put MOUs in place. And so we essentially repurposed those staff. Instead of just doing day center intake for those locations, we had them do coordinated entry assessments, which would generate that enrollment into HMIS for ESG requirements, but we were still able to have them do the entire coordinated entry assessment. So that is how we funded the first assessors. And then the same thing at the women and family shelter. We had people that were intaking clients into the shelter that we just trained to do the coordinated entry assessments. And then for the navigators, we had an old supportive services only grant that was funded through the Continuum of Care that was specifically to navigate individuals experiencing homelessness into housing. And so what we did is we decided as a system to protect that grant and repurposed the staff that were on that grant to coordinated entry to do navigation. And so they became the two first navigators for our system. From there, in order to keep it transparent and to stay true to our new collaborative model, we had coordinated access work groups. And so we basically went out, we just put out a call to the community, to all of our partners, and said, who would like to participate in the coordinated access work group to help build our system, to help create what coordinated access was going to be. And so we had a core group of individuals that met every week, and we kept meeting until all the work was done. So we created the tools, the questions, the assessments, the locations, how the staffing was going to work with partners. The transition team were individuals, staff from the organizations that we repurposed staff from. And so we met day to day to monitor the action on the ground, the hours, staffing, et cetera. We then added a permanent supportive housing work group to create the first by name list for permanent supportive housing. They developed the forms that was going to be used for the entire system instead of having each project have their own individual forms. In 2015, we added rapid rehousing. We had a COC funded rapid rehousing. So we figured out how to add families. We had a rapid rehousing work group to manage funding streams requirements. It was a system model rapid rehousing. And so that is how we were able to oversee and stay true to the process. All of the work that came out of those work groups went to the COC steering committee for a vote, and then was then implemented by the the lead agency, which was the Coalition for the Homeless. So that is all for my slides, and I'm going to pause there to see if there are any.
Yes, do we have any brief questions? We'll give you just a couple seconds here before we move on. I don't see any questions for Anna right now. Okay, good. We have one right here. For the jail coordinated access point, are you only assessing folks meeting Cat 1 and 4 homeless definition, or anyone being discharged?
It was individuals. So we actually had a jail diversion permanent supportive housing project that worked with our largest mental health provider. And so they would do is we trained their staff to do assessments in the jails. And then they were able to call our intake line to do assessments. And so the way that it worked is that it was for people that were homeless prior to going to jail. And then we're going to be homeless after, and we're working with the MHMRA provider. And so we did not have, they were being discharged. It wasn't anyone that was being discharged. It was just the individuals that were experiencing literal homelessness prior to going into jail.
We have another question. How did you get funding into your CES system for your access sites?
So we didn't get funding in the beginning. So as I mentioned, we repurposed staff from organizations that were funded through ESG and were already doing ESG intake. We went to the funders for the city and the county and got their permission. And then we went to the actual organizations and asked them to repurpose their staff. And then, we just moved them to do assessments for the entire system. Do you want me to answer the question about the assessment?
I think that'll be coming up in the next part of the presentation. So I think we can move on. Yeah. So Errol, take it away.
Okay, wonderful. I hope everybody can hear me. Hello, good morning and good afternoon, depending on where you live. Again, my name is Errol and I work in the Coalition HMIS department. So I'd like to take you back a little bit and to cover or recover something that Anna already mentioned, the way that we initially built the coordinate access within our HMIS and ClientConnect software. So back in 2013, we had so many questions. Okay, we had no idea where to start from because, again, this was all new to everybody. But from the get-go, what we wanted to do is to make sure that, first of all, we use the HMIS for any coordinate access data, including any waitlist or by name list or referrals or anything like that. And then we also wanted to make sure that the data sharing is not an issue, that all the clients who are entered in the HMIS, in the coordinate access piece, that their data can be shared without many barriers. We know that in ClientConnect and many other HMI solutions, there are built-in security, functions. So in ClientConnect, the main thing is the organizational ID. This is how the data gets shared between different organizations. For coordinated access or coordinated entry, what we decided to do is basically to create one umbrella organization for the entire system so that we won't have to worry about whether a release of information has been created, whether somebody who is approved to participate in the HMIs in the coordinated access piece, they can see everything that they need to. So this is how we initially kind of created that structure. Everything was built in ClientConnect in the HMIS, and we used one umbrella organization. Then we assigned the appropriate users who received additional trainings for coordinated access specific activities under that organization. And that way everybody was able to see everything. That, I think, really worked well for us because, without good data sharing, I have to reiterate it, coordinated access, I don't know how it can actually work. Again, the client is initially asked to sign off on the release information, and that release is kind of pretty broad, and it is electronic within ClientConnect. So they can kind of sign it with their initials, or the case manager can witness, and so on. So we really have not had any issues on that end. It worked great. There's only one piece that is not part of this same umbrella, and that is the domestic violence shelters. They also operate, kind of their own coordinated access system, but again, due to the VAWA restriction, they cannot directly enter into the HMIS. So initially back in 2013, we worked with Ecovia, with our vendor, and we were fortunate enough that, ClientConnect was, as a software, allowed us to basically, build it the way that we wanted. There, again, at that time, there were no HMS standards for the coordinated entry. So we kind of, used our best judgment. We did have our steering committee who approved all of the changes. And then we just, built it like that. We told the Ecovia what we needed, what we would like to do, to have in the HMIS as far as all the forms and all the workflows. They designed it, and it worked fine for a while. Initially, we used the vulnerability index, the VI, not the VI SPDAT, but just the VI. It was a very simple assessment tool. And that kind of worked for a couple of years, and then we redesigned it by introducing our own locally developed assessment tool. And I think my colleague Jordan is going to talk about it a little more. So then we also created a coordinated access specific work group. I'm sorry, yes, still at the same page. I mean, I'm just like going over these bullets. I
no worries, just making sure.
Yeah, no problem. I probably should have included a little more information on here. So what you're looking at basically is our current by name list. Over the years, we had many iterations of different wait lists, by name lists, and so on. Just recently, we renamed it. And if you hear any noise in the background, it's a train coming right through my neighborhood. So I apologize for that. So just recently, we renamed it to the by name list, and we basically repurposed the waitlist form that existed within ClientConnect, and we made it into the coordinated access by name list. This form has many filters so that the assessor or the person who is going to refer a client, they can do that quickly by just filtering on the different demographic and different clients information. And just to mention, we also created a specific work group within ClientConnect. Those of you who are ClientConnect users, you know that ClientConnect offers different work groups based on user roles. So that's how we kind of made all these customizations only applicable to the coordinated access users. I know that many other communities, they have a different model. They may even have the by name list in a separate system other than, within the HMIS. I don't really know how that can truly work, but you know, there's all kinds of different ways to design the system. If it works, it's great. This is how it worked for us. Yeah, so this is, I think that for my piece for the first slide. Let me just make sure that I haven't skipped anything. Yeah, so for the data elements then, as I said, initially, we didn't really have a whole lot of guidelines from HUD. And when I say from HUD, I mean primarily HMI's data standards. You know, we did comply with the demographic information and all of that, but the way that we initially built it is we didn't even have an enrollment requirement. We only created the assessment. We completed that VI tool, and then we would place the client on the wait list or the by name list, and then we would refer them out when an opening was available. And then in fiscal year 2020, HUD came with their own HMS data standards for the code entry. And what that required us to do is basically go back and kind of fit our existing structure into this new data standard. But let me tell you, this was a bit challenging, okay? We still have a few of those elements that are still kind of redundant, which means we ask the same question 2 or 3 times, depending on the workflow, but we actually have to do that. But we are trying to streamline the workflow so that you know, the assessors don't spend too much time with the clients answering all these questions with, you know, limited result. So with the rollout, we, you know, made sure that we started to collect everything that was required by HUD, because we did receive eventually two HUD grants for coordinated entry. And then we are required to submit the APR. That is what you're looking at on the screen. This is a screenshot from the Sage portal. I think everybody who receives HUD funding is familiar with this. This is a screenshot of our last year's code entry APR. So the APR, basically, same as any other APR, we do have to generate a data file, which is quite different than the like housing or you know, permanent housing or outreach data. This is specific to coordinate entry data. And this data includes events and assessments and things like that, placements on the prioritization list. So we had to make sure that all of that kind of works with how we originally set it up in our system. One key thing that we use in ClientConnect is the electronic referrals. And I think Anna already mentioned that. The referrals give us the ability to generate email notifications. So when a client is referred from the coordinate access to a housing provider, you know, we send that electronic referral via email. Well, that works fine for the referral form, but the event, the coordinate access event form did not have that functionality. So we had to kind of bridge that gap between the two to make it work. Yeah, so that's as far as the HMI's data standards. I think we're still, I mean, last year they did not make almost any changes, but HUD generally, you know, introduces these changes every October. Now they're kind of putting a pause on this, so this is good for us and for everybody, so that, you know, we have the idea and the ability to reevaluate how all of our data works. Next slide, please. And again, so this is the screenshot of our referral on the left-hand side. So basically, if you look at this referral, it just sends an email from my account to the housing provider, and it includes some basic information about the client, including the contact information. As far as the contact information, that is really, really important to have in the system. That is not a standard HMI's data. That is something that we have in ClientConnect, and we customize it a little bit as well, because we want to make sure that if a client gets assessed, that we at least have a way to contact them when they, you know, when they're up for a housing referral. So we prefer to, record their email and their phone number in the system, and we update those as needed. So basically, I mentioned that we have a subset of our HMI users who receive additional training. Currently, it's about 230 out of more than 1,000 HMIS users that we have in the system that have been approved and that receive training for code access, and they enter the data or write reports basically for the code entry uses. Many of them are assessors, but not all. I mean, we do have some administrators and some navigators and things like that. And then through the code entry during the last 12 months, we housed that many people, 2340. Actually, I just reran the number and it's like 2360 by now, because when I submitted this slide, you know how it is with the data entry. Sometimes it takes a while for somebody to enter that move-in date in the system, and that's how we measure the housing placement. So we constantly run reports, different types of reports. The query designer, those of you who are familiar with that function in ClientConnect, that is really a key piece of our admin work. We use queries all the time. We run these queries to see missing data, both for the code entry and in general. We use that to, inform the assessors whether they need to go back and, check on something. And then again, we try to analyze the performance of both the entire system and then the code access piece as well that kind of works within that system. And that is about the end of my segment. I would just give a few tips to other COCs. If you are still new with this process, or if you have any questions, talk to your HMS vendor, definitely, see what the capabilities are. If it is Ecovia, I kind of explained what we did. If it's another vendor, then all of them should be able to support you to right-size the code access system based on your community, because one size does not fit all. We have very small COCs to very large ones, and everybody has to kind of put some effort to create these some customization locally, I think. So thank you so much, and I wonder if there are any questions for me.
Yeah, I think we have one. This might be best answered by Melissa, but the question is there functionality around sending the referral notification email to all key contacts for the client, such as the case managers, assessors, shelter advocates, and client themselves?
We actually just spoke with our account representative over at Ecovia today, and we were talking about the ability to send emails to clients. That, to my knowledge, is not yet available in ClientConnect, and I don't think that we can send emails to like multiple accounts at once, unless you go in and just kind of manually adjust this default email that I'm showing on the screen. So yeah, definitely communication between different code entry users and clients is really a key.
Thank you. Wonderful. Next up, we have Renee.
Actually, it's going to be me, Jordan.
Great. Wonderful. Thank you, Jordan.
No worries. We'll go ahead and get started. You will kind of see some of the content that I'm covering. Anna has discussed, Errol has discussed, but I like to always start all of our anytime I'm speaking, start out and say our kind of community distinctions that I think are really important when thinking through potential implementation or major takeaways from anything that we're presenting here. One being the Coalition for the Homeless, CFTH, is the COC, CA, and HMIS lead. A lot of communities, this is kind of broken out between government agencies, other nonprofits, and they don't all live under one roof. And I think that is very important to understand as far as like how much ground we've been able to cover, how successful we've been able to be. Not saying that you couldn't be otherwise, but I think that really speaks to us all being under one house, and I can just go by Errol's office and say, will you change this one thing real quick? And it's, I'm CA and he's HMIS, but we're right there. And then because we're the COC lead, we can, ideally make that decision with steering committee approval. The other thing that I think is very important to understand is that our coordinated access system or coordinated entry system only facilitates intake for housing prioritization and referral to permanent housing or diversion services. Our system is not set up for entry into services such as shelter, day center, prevention. Some supportive services are inside of our coordinated entry process. We identify that as a big gap and something that we, hope to work towards in the future. And Renee will speak in a little bit about like future iterations of what we're hoping to achieve. But that's also an important community distinction, because a lot of communities utilize coordinated entry and they will say you are going into XYZ shelter or some other sort of supportive service, and there may be a component of housing to that as well. But those things are not a part of ours currently. We can move on to the next slide. When Anna was presenting, she talked a lot about the tool, the workflow, the historical context to it. And on our screen here is our current local housing prioritization tool assessment. So these are the locally developed questions that we are utilizing to gauge individuals' vulnerability. So these are built into our coordinated access workflow in tandem with the HUD required elements. And so this is what we see as being useful for our community. I think that, certainly these questions could be used in other places, but they also may not be relevant. And so I just want to put that distinction out there. There are 16 questions here, and so they all have an associated score with them. This gets at vulnerability and then eligibility. So it's one comprehensive workflow. It adjusts eligibility and level of vulnerability based on data entry. So this kind of calculates in real time. This used to be something that the assessor would be able to see totaling up to the max score. So as they answered the question, they would see it jump 4 points or jump 2 points or jump 1 or whatever it may be. And if you were like somewhat, savvy, you would start to register that if you answered certain questions, you could increase the client's vulnerability and their, likelihood of getting a referral to a certain place. And so that's actually something that we recently removed. We don't display the score. We kind of readjusted this within the past year. The point allocation was readjusted, that is. And then you can't see in real time how the prioritization is ticking. So whether it's 1 point or 4 points, the person's not going to know. They have no idea which question has which, point allocation, or if it even has a point allocation adjusted or, connected to it. So that's something that we're proud of. We think it's helped us reduce bias in our system. What are some other high points about this? So we use this housing prioritization tool or housing, it measures vulnerability, but we also utilize other HMIS data to influence our overall prioritization. So unfortunately, we do operate off of a by name list. Most people, most of the time, are not getting referred directly to a housing provider or any sort of, service provider. They're just going straight on our bio name list, and they may be on there for a while, unfortunately. So we utilize other things like frequency status. So we're able to calculate how many times in, a certain, I think it's 5 months, if someone's visited a service or received a service from a homeless response provider 5 times within the last 3 months or 5 months, then they would be considered frequent. So that's something that we've looked up historically to help us say, okay, this person's like utilizing services. We know that they're around. They're not resolving their homelessness on their own. Other system logic is one we recently implemented, which is populating current enrollments in an emergency shelter, a day center, a street outreach project, or a domestic violence provider from our overall by name list. So if we have 1,000 people on the by name list, we can kind of filter through them and see who is currently enrolled with one of our system service providers, and we would identify those as also being vulnerable individuals. So those are just some kind of savvy, nuanced things that we're proud of as far as our prioritization goes. We can move on to the next slide. Access and operating in a large COC. Anna talked about this. Errol talked about this. They have a lot of like historic knowledge regarding this, but we really like where we sit currently is we offer a multifaceted approach to address access. One thing that, Anna spoke to was the hubs, and we started at the Women and Family, and we started at the Beacon, which is where I used to work, implementing this. And so we certainly have a presence in some of our brick and mortar service provider locations, almost all of our shelters. We have 30 partners that offer coordinated access on site. We also operate a support line, which is basically like a hotline or any other kind of phone line. We have 28 service providers connecting to us through that. So, those are typically places that may be small, they're grassroots, they're domestic violence, so they don't enter an HMIS or something like that. And so they need kind of a bridge, and we utilize a, support line to do that. And then we have also recently, within the last year at least, been able to take on actually going out physically to sites. So 14 agencies right now are in rotation that we go on site and meet these clients there. And with the facilitation of agencies. And so a lot happening like inside existing agencies, and we see that being very, very valuable. Like Anna said, meeting people where they are is super important, always going to be vital to the homeless response system and addressing those needs. But we also we also know that a lot of people don't access services there, especially in our COC. We have a large unincorporated areas of like rural communities. 33% of Houston's homeless population was unsheltered according to our most recent point in time count data. And so that's a large percentage that, we're not meeting if we say you have to go somewhere in person. And so we're working on developing a tool that either they can access on their own and say, hey, I can't make it to a place in person. I need you to come visit me. We would call it like an outreach request, or someone can do it on this person's behalf. I identify someone in my neighborhood, I speak with them, this is something that they're interested in, and I submit the request on their behalf because they don't have a phone or can't make it to a library or whatever it is. And so that's something that we're working on, and I'm really excited about, building out this public facing platform. A few other things that I'll just quickly kind of get through so I can get it off to Renee is we have a strong collaboration with the DV community that we're proud of. Like Errol said, the domestic violence community has their own coordinated entry process because they do not enter into HMIS or our homeless response system HMIS. And so we work really hard to make sure we have strong connections with all of the domestic violence shelters, all of the potential day centers, their advocates, and they either utilize our intake line or they send us direct referrals. And so we're proud of that process. Could always be better, but it's definitely something that has improved over the last 5 years or so. And then lastly, something that I kind of thought of while we were going through this, I think something that allows us to be so successful with coordinated access is the duality of the role of being an assessor. You can be an HMIS user. Like Errol said, we have about 1,000 HMIS users or more. And any one of those, depending on the role that they have in the homeless response system or in the community at large, could become an assessor. And I think that makes it really easy for us to access or be accessible to people that we otherwise wouldn't. An outreach person can be an assessor. A day center intake person can be an assessor. An income program case manager can be an assessor. And that is something that I think helps us as well. So I am finished. I don't know if there are any questions before we head over to Renee.
Yeah, do we have any last questions? We had one from Danica that was in the chat for that Anna was kind of going back and forth with her on. But do we have any other questions in the chat? I don't see. Oh, okay, here's one. How are housing referrals made for the DV population? On the PL, I assume that means. Well, let me see. I'm trying to. Oh, priority list. Thank you.
How are housing the same way that they would be for anyone else in our continuum of care. So that referral is made to the housing provider, and then the housing provider works backwards to contact the client. We do have emergency contact information listed. Sometimes, the DV, well, it really is whoever the client chooses to list as their emergency contact person. It could be friends or family, or it could be their, domestic violence case manager, but the referrals are done the exact same way. And I think Errol may be able to speak a little bit more to the way that we're able to make referrals for the DV community once they enter our system versus, the justification for DV having their own coordinated entry outside of our system.
Yeah. I mean, with the DV system, I think the communication kind of works one way. We can refer to the DV shelters, but they cannot refer back, right? Because they cannot reveal client identity. So we do have a couple of ways to refer clients. There is the local main DV shelter phone number. Sometimes, that can be provided to the client, or, the assessor can make that call on their behalf. But again, if a person fleeing domestic violence enters the regular system, so to say, they can be entered in the HMIS. That's not an issue. The issue is just getting that information back from the DV shelters, which we can't due to the prohibition.
Thank you, Errol and Jordan. Okay, so coming up then we have Renee. Renee, are you ready?
I am, yes.
Wonderful.
All righty. Well, thank you, Anna, Errol, and Jordan. I get the honor of wrapping us up today. So as Jordan mentioned, our CA Coordinate Access System is an ever-evolving framework designed to meet the dynamic needs of our community. We are really committed to regularly assessing and identifying gaps to enhance both efficiency and effectiveness. Over the past year, we have implemented substantial improvements with even more on the way. We believe it's crucial for our system to continue to adapt in order to address the changing demands of the landscape and shape of our community. This fall, we aim to expand on this by conducting a more comprehensive equity analysis to ensure fairness and inclusivity in both access and experience. Next slide, please. Of course, as mentioned, community engagement is crucial to our coordinated access success. We involve community partners in work groups to shape our strategies and solutions. We also analyze our point in time count data and ongoing CA data. We use this to identify system gaps and address any issues. This ongoing collaboration, again, just ensures that our system remains responsive, inclusive, and accountable to our community's needs and strengths. Next slide, please. And of course, at the heart of our CA system are the voices and experiences of our consumers within our region and individuals of lived experience. Our Consumer Advisory Committee and Youth Advisory Board provide invaluable insights, ensuring our programs are effective, empathetic, and responsive. Incorporating their perspectives helps build a more inclusive system. I think in summary, our CA system thrives on robust community engagement and contributions from those with lived experience and our various partners. By involving our partners' advisory boards, we ensure our system remains dynamic and effective. And we continue to be committed to refining our processes, addressing any emerging needs, and fostering stronger collaboration for the future.
Thank you, Renee. That was a great way to wrap this up. We have one last opportunity for everyone to ask any of your burning questions, anything that you'd like a little bit more detail on or some clarification on. Please put them in the chat. I think we're willing to go over a little bit the hour. That's fine with me if that's fine with everyone else. Okay, here's our first question. How did you manage to increase your housing supply by so much so quickly? I assume you're referring to that 10-year period. Yes. Perfect.
Do you want me to answer that verbally?
Yes, that would be great.
So we did a lot of different things. One of the things that we did is we went through a process of removing or eliminating the COC-funded transitional housing programs, and we reallocated those dollars to permanent supportive housing. So that enabled us to create new housing slots. We also have homeless preferences in place with our both of our housing authorities, so the Houston and Harris County housing authorities. And so we looked at our COC-funded PSH projects. And so, for example, if you had a PSH project where you were serving 50 people and you were paying rent for 50 people and providing supportive services for 50 people, we enabled that project to enter into a grant amendment, moving the rental assistance to supportive services so that they could serve 100 people. And then we got housing choice vouchers or Section 8 vouchers to pay the subsidy. And so we did a lot of that with a lot of PSH projects. And so that enabled us to increase our PSH slots. And then when, our 5-year strategic plan there was some rehab, there was some local, home and disaster dollars that were used for some rehab for some existing properties. And then we do have a large SRO provider that we partner with, that we put project-based vouchers for individuals experiencing homelessness at those properties. And then we paired those with new permanent supportive housing programs. So those are just kind of what we've done. We also really work to increase to, really beef up our narrative on the NOFO, really working on a system-wide level to improve our scoring. So we added coordinated entry to our scoring, just things that made us to where we scored really high on the NOFO, which enabled us to get more COC bonus projects. And so we don't get a lot of support. We don't get any, actually. Houston is a revenue cap city. We don't receive local dollars for homelessness. We only get the bulk of our resources is through the continuum of care. So that is why we focus so heavily on improving our COC process.
Thank you, Anna. That was very helpful. Do we have any other questions? Yes, Kenya. Kenya said we might need an additional slide for that answer. That was really great. Pending any other questions, I believe that takes care of us for today. I've put a link in the chat here for our next webinar with Partners for Home from Atlanta. We will be doing another webinar with them about about closed loop referral specifically, and as well as data sharing. So there's another opportunity to learn from another community that has achieved great outcomes for clients, specifically with coordinated access. So everyone, please, if you don't mind, give a virtual applause for our presenters. We really admire communities. This is all part of our ClientConnect series to help connect communities who want to learn from each other on how to improve social determinants of health. And we thank you for your time, and thank you everyone for attending today.